I'm from the Mayo Clinic in Rochester, Minnesota, here in the U.S., and I'm going to chat briefly this morning here in the U.S. On immunotherapy for the treatment of ALL. So we can go to the next slide. So, what are immunotherapies? Simply stated, immunotherapies are a type of treatment that helps your body's own immune system fight cancer. And so scientists and physicians have adapted aspects of the immune system to make this possible. Why does our immune system need help to fight cancer? Well, cancer cells can hide actually from the immune system or can develop mechanisms to ignore signals from the immune system. We do think our normal immune system sometimes can be helpful in controlling cancer, but obviously it doesn't do that perfectly because unfortunately people do develop different cancers. And so why do we use this approach? Well, we've reached, we think, the limits of what we can do with chemotherapy, and chemotherapy has a lot of side effects. Some of the advantages of immunotherapy is that they're what we call a targeted approach. So they attack the cancer cells specifically. Sometimes they can affect some of the normal cells, but to much lesser extent than chemotherapy does. And so they are more of this targeted approach. We found that they can be very effective. And oftentimes when someone is exhausted, other forms of treatment, specifically chemotherapy, immunotherapies have been found to be effective in that setting and have not infrequently led to long-term control and even, we think, cures of the leukemia. So there are three basic types of immunotherapy that we're currently employing in the use of acute lymphoblastic leukemia. One are what are called bispecific antibodies. So antibodies are proteins that our immune system makes that attach to infectious organisms and send a signal to the white blood cells to come and kill it. And so scientists have now made antibodies, though, that instead of reacting with bacteria, react with cells. And so they find and attach to the cancer cell. And the bispecific term means that we've taken two antibodies and we've linked them together. And so one antibody reacts to the leukemia cell, and the other antibody brings another cell of the immune system called a T cell. T stands for thymocyte, and the thymus is a gland in our chest where these cells come from. So it's going to bring this T cell close to the leukemia cell so it can kill it. And the notable example of this is an agent called blinatumomab that has been found to be very effective in this regard. Sort of a step up, I'll say, from blinatumomab is what are called CAR T cell therapy, and CAR stands for chimeric antigen receptor. And so in this approach, we've actually taken one of these T cells that I just talked about and put an antibody into the T cell, so it's on the surface. So it's in a way bringing the T cell also right up to the leukemia cell. So sort of doing what blinatumomab does, but in a different way, and we do think in somewhat more potent way, although both of these approaches have some side effects. So these T cells in the CAR T cell attack the leukemia cell and can destroy it. And there's two of these that have been approved. There's actually a third one now in the United States, but the first two that were identified are this these very long words: tisagenlecleucel and brexucabtagene autoleucel, and these describe these two different CAR T cells. And then the last one is this antibody drug conjugate. So in this situation, we've taken an antibody and we've been able to attach a chemotherapy drug to it. And so in this way, the antibody is reacting against the leukemia cell and it's delivering the chemotherapy drug right to the cell. And so the chemotherapy is not affecting some of the other organs in the body to such an extent as is seen with regular chemotherapy. So again, we're delivering the chemotherapy drug to the leukemia cell via the antibody. And the notable agent in this regard is one called inotuzumab ozogamicin. And so these are all of these examples here are ones that are approved by different regulatory bodies in different countries. In the United States, by the FDA, the Food and Drug Administration. Although immunotherapy we think has less side effects than chemotherapy, it still does have some side effects, and these occur to a variable extent. And sometimes the side effects are actually a sign that the immunotherapy is working well. Because when the leukemia cells are attacked and break down, they can release different proteins or what we call cytokines into the bloodstream that can cause some of these side effects. So you can see this list here: fatigue. Some people can get rashes that can cause itching, headaches, body pain. This cytokine, when these cytokines are released from the cell, they cause what's called cytokine release syndrome, and that can cause low blood pressure, can cause the fever and chills, the fast heartbeat that you see here. Sometimes this can affect the nervous system and cause some confusion and speech problems. There's a headache you can see there. Sometimes it temporarily affects the blood counts and they can go down. And it can also sometimes affect the gastrointestinal system. So this doesn't happen in every situation and with every patient, but these are some of the side effects that physicians and nurses need to monitor the patients for.
As to what Dr. Litzow had discussed a little bit with immunotherapy, that was part of my treatment. Again, I was 35 years old in my prime when I was diagnosed with Philadelphia chromosome positive B cell ALL. I was working as a foot and ankle surgeon, had just launched my own private practice in combination with my wife, who's a physical therapist, in July of 2023. And in August of 2023, started experience severe fatigue and some bone pain that we chalked up initially to our pretty active hiking and adventurous lifestyle. We had gone whitewater rafting and had done a bunch of camping with our dogs. And I figured, you know, I'm mid-30s and it's all catching up with me now. But by mid-August, I was having some pretty severe difficulty even just getting my scrubs on in the morning. It's the pain was becoming localized to my collarbone and then into my TMJ, and you sort of brush things off and, oh, you know, I can treat this with 800 milligrams of ibuprofen, and you know, it wasn't helping, and I was suffering and trying to get through seeing patients and then trying to do notes, and it just, things weren't, it wasn't normal. It wasn't normal tired. And so at the end of August, early September, woke up one morning ready to go see patients and started having some severe chest pain, and knew at that point I needed to go in. So because I didn't want to take multiple days off from seeing patients, I just went to the emergency room, figured they could do the smattering of tests on me, figured it was an electrolyte imbalance from the past month of being a little bit run down, and that I'd be discharged after an IV that day. Wasn't expecting a month-long admission or a leukemia diagnosis, but that's what ended up happening. In the emergency room, they came back and said that my blood smear was abnormal and that I needed a bone marrow biopsy, and that confirmed my leukemia diagnosis. And I said, "You have the wrong room. I'm here for collarbone pain." And later found out that I had had a pathological fracture of my collarbone secondary to the leukemia. So was admitted to my local ER And then given my age range, the oncologist there had not experienced treatment for ALL in young adults. He specifically had only treated children, as it's the most common cancer in children, or the most common leukemia in children. So I was then transferred to City of Hope Cancer Center out here in Southern California. And there met with my hemonc and treatment team, and had pretty much immediate confidence in how they presented the protocol, and was induced or had my induction phase with vincristine and dexamethasone, and then the tyrosine kinase inhibitor ponatinib for my Philadelphia chromosome status. That treated that aspect of it. And I was on the higher milligram dosage for that during induction phase, and then later reduced to a treatment, or later reduced to 15 milligrams later in treatment. My doctor did recommend immunotherapies, specifically blinatumomab, in combination with the TKI versus a bone marrow transplant, just given his research and his experience with these new treatments coming out and their success rates in getting younger, healthier people into remission without having to go through the bone marrow transplant. And even though bone marrow transplants were, at one point the standard of care and gold standard in terms of curative treatments and things like that, they are a bear to go through. And so I jumped at the chance to try the immunotherapy approach and was treated with 5 cycles of blinatumomab, each lasting 28 days, followed by a 14-day break. And that lasted from October 2023 to May 2024. And I was treated through a PICC line and the little satchel that comes with me at home. And honestly, it was pretty great compared to the chemo that I had experienced in the induction phase. I did have some side effects that I'll go into. And as of now, today, I am in remission, still taking my TKI, which there's still research coming out about that, how long I'll need to stay on that. A low-dose aspirin, given the side effects that can happen with the TKI of ponatinib, and then prophylactic antivirals. So go to the next slide. As for my experience with side effects, I experienced probably the most notable side effect was the body pain and the fatigue. Specifically with the body pain, I had like some deep bone pain in my hips, and then like cramping and muscle spasms in my legs. And then with the fatigue, I was sleeping about 12 hours a day, and thankfully I have a wonderful partner who is able to head things up at home. And rest is just as healing as other modalities in some ways. But the fatigue was something that was notable, as it was, up to 12 to 14 hours a day pretty regularly. And then I did experience, and still do experience, brain fog, some difficulty with like word recall, as you might notice in some of my speaking engagements. But that has slowly come back, and working still with short-term memory and just some things to try to navigate that aspect of the side effects. And then infections were common while I was on immunotherapy. It's hard to say if that was directly related to the immunotherapy. My hemonc couldn't say if it was for certain, or if it was just related to my poor immune system from treatment and leukemia. But I was getting a mild cold about 1 to 2 times a month. No inpatient treatment required, thankfully. But it was to the point where I was pretty sick with either strep throat or some viral infection for at least a week every month that I was on the blinatumomab. In regards to how I manage some of these side effects, in terms of the body pain, I did talk to my provider about that and the spasms in my legs specifically, and he prescribed the cyclobenzaprine, which is a muscle relaxant, just a low dose, and that did help. I wouldn't say that it was hugely significant in terms of relief. What I did find, which provided some pretty significant relief for me daily and nightly, were what I call my legs. Their sequential compression leg recovery system. So, if you go on Amazon or on Google, they're basically the compression leg sleeves that you can either have at home, or some of the new like med spa clinics offer them as just help in terms of vasculature and relaxing your musculature. And I did find that I was pretty much almost living in those, at least in the mornings, and at night I would fall asleep in them. I would take the cyclobenzaprine about 3 times a week. It did cause more drowsiness, but it did help sort of take the edge off of the muscle spasms when they would get particularly bad. In terms of fatigue, I was prescribed a combination pill of acetaminophen, butalbital, and caffeine. And along with that fatigue, I would often get the headaches that were also discussed in terms of common side effects. And so rest, and then I had like one of the cold packs to my head that would help, and I would just sort of fall asleep or close my eyes, and the sleeping 12 hours a day helped with some of that, but also I sort of wanted to gain some of my strength back, because I was pretty deconditioned after my induction phase of treatment. So I didn't want to spend all day in bed. And in terms of my brain fog, the caffeine that was in the combination pill definitely helped with my mental acuity. I would continue to try to read. I was a big reader beforehand. And then just some like cognitive memory games and puzzles that we had around the house, just to sort of keep my mind active, even though it was pretty exhausting. As far as the infections go, I was on the prophylactic antivirals and antibiotics. And then I was also, wearing my mask whenever I'd have to go out in public, gloves, hand hygiene. We'd have, people come, any nurses that came into the house had to sanitize and wear masks, and just avoiding crowds. And despite all of that, was still developing infections 1 to 2 times a month. But again, nothing severe enough to require an inpatient treatment. So grateful in that regard, but it was exhausting kind of being sick while being sick. As far as like improving the patient experience in regards to the immunotherapy aspect, I think patient education is obviously important. I think a more thorough explanation of what the expected side effects and the duration of the side effects would be helpful. I know that when it was presented to me, the immunotherapy was sort of presented exactly as discussed earlier. It's like a targeted treatment, less side effects, more effective, and it got me into remission after my first cycle, but I wasn't educated on like what those side effects were and what the level of those could be and the impact that they would have on my daily life. And then also coupling with that, the ancillary interventions that can help mitigate those side effects. So yes, a couple of the prescription medications did help, but all of the other things that I found that helped me were sort of, I had to find on my own, and which is fine, but it would be sort of nice to say, oh, like if you experience this, try this, or this has helped with other patients. And so you're not feeling as lost and overwhelmed as you're going through such a pivotal time in your life. And then connecting patients directly to support groups, such as this. And I know that I was given a pamphlet, I believe, by like a social worker that came through one day during my inpatient process and was like, here's a pamphlet to the Leukemia and Lymphoma Society. They have good resources. And that was like the end of the discussion. And the pamphlet helped, but there are also so many other support groups and like a way of directly connecting patients that I think could definitely be improved upon. I know I did a lot of that once I was in my maintenance or in my consolidation phase at home, and sort of feeling a little bit better and trying to engage and connect with people that were either going through what I have gone through or with healthcare providers and understanding my treatment process. And then finally, caregiver education, specifically, you know, in terms of the help with the ADLs that the patient's going to need. I know, like I mentioned, my partner had to pick up a lot of that, which is to be expected, you know, with a cancer patient of any regard or any person who is sick. But just, you know, the deconditioning, and I was wheelchair bound for about a month, and then, you know, dog walking, grocery shopping, all of those things. And then the other big point was the financial barrier. I know that blinatumomab is one of the most expensive drugs on the market, and insurance coverage can be good depending on you know, what part of the world you're in, and what state you're in and what plan you have if you're in the US. But it can be pretty overwhelming if you don't have access to that, or it can be completely unavailable, as I've found in connecting with people across the world, even down, you know, just south of the border from us in Mexico. People, there are patients that don't have access to it, and then, you know, have to go through some pretty brutal rounds of chemotherapy when something like an immunotherapy could be so beneficial to them. And then in that vein, patient assistance programs or financial assistance programs. Again, I think this could be something that like the cancer centers or the treatment centers could really improve upon, in terms of having either like a social worker take that on, or having a specific liaison present those assistance programs to patients. I know that I was offered that for the TKI that I'm on, but a lot of that was done, that research was done on my partner and family's behalf, of sort of navigating what we could apply for, and it wasn't as readily accessible as I think it should be for a patient, and things that I would do for my patients as a health care provider, obviously not in the cancer side of things, but just in prescription management for different treatments. I would always be on the lookout for those things to help assist with patients, because the cost of these things is pretty exorbitant. And then one thing that I found that really improved my experience was receiving my blinatumomab at home. So the first 2 cycles were through the City of Hope Infusion Center, and I would go in for my appointment and then go sit for, you know, 4 hours while I waited for them to change my PICC line and start my next bag of blinatumomab. And I was exhausted at this point. It was early in my treatment. And then also being exposed, even though everyone was masked in the cancer center, you're still, you know, have a really frail immune system, and you're being exposed to a lot of people. And the final 3 cycles, I was actually given the opportunity to have it done at home through a home health nurse, and found that to be much more simplified. I was just scheduled it with the nurse, and they had everything sent to the house, and was able to rest and not be exposed to, you know, hundreds of people, and not have to wait for 4 hours for a nurse to come change my PICC line. And found that to be, you know, one of the highlights actually of my treatment was being treated in the comfort of my own home, and I didn't even know that was possible. So that would be something that I would definitely recommend for providers and patients alike to advocate for.
So managing some of the side effects, I mentioned the cytokine release syndrome. There's a side effect of the CAR T-cell therapy and the bispecific antibody therapy, in this case, blinatumomab. And this happens because when the blinatumomab, the bispecific antibody, or the CAR T-cell, when it engages with a leukemia cell and kills it, the leukemia cell and some of the other immune cells, some of the T cells themselves, become activated, and these proteins are released, and that's what these immune signals, it says here, or cytokines are, and they cause inflammation in the body. I sometimes tell people, when you have the flu, it's not so much the virus that's making you directly sick. It's your immune system reaction to the virus that's causing you to have aching and fever and not feel so good. And so this inflammation sometimes can be severe, and it can damage some of the normal healthy tissues and the organs in the body. And the spectrum of how it affects a person can range from, as it says here, mild flu-like symptoms, but it can be more severe with fever, difficulty breathing, and organ failure. And sometimes people end up in the intensive care unit. And this tends to happen more when there are large amounts of leukemia in the body that the immunotherapy is being used against. And so being on the lookout for this, prompt diagnosis and rapid management is essential to minimize these serious complications. And so we actually grade, there's a standard grading that has been developed for cytokine release syndrome. And this grading helps us as healthcare providers decide, what treatment is needed. So grade 1 is a mild form where people can have a fever, feel chilled and tired. And here we need to monitor them carefully to make sure it's not progressing more. We need to rule out infection. That's an important aspect of this. And then if we're convinced that this is cytokine release syndrome, we can give intravenous fluids to help control the blood pressure, and then we'll sometimes use steroids to counteract the inflammation. The moderate severity is somewhat more severe. The blood pressure can start to go down. Their oxygen level can decrease. And so we give oxygen, we give IV fluids to maintain the help maintain the blood pressure. We'll use steroids again. And then there's another antibody treatment that's called tocilizumab. And there are a whole variety of cytokines that are released, and some of these are what we call interleukins, and we number these, and there's one called interleukin-6, and tocilizumab counteracts the effects of interleukin-6, and interleukin-6 levels can go very high and contribute to this low blood pressure, shortness of breath, and fever. And then there's the more severe forms of cytokine release syndrome. And again, some of the same symptoms, but in a more severe form. And in the case of blinatumomab, we can stop the blinatumomab if we're seeing more severe forms of cytokine release syndrome, then also give the tocilizumab and the steroids. We can't really stop the CAR T-cell therapy because once that's given, once those cells are infused into a person, they're there. We can't take them out. So we just need to use the medications and IV fluids and so on to counteract the effects of the cytokine release syndrome and support a person so that they can get through this phase of the treatment. The other major side effect is this term we use, neurotoxicity, and neuro refers to the neurologic system, and toxicity is side effects. It's less clear what causes this neurotoxicity, although we do think that it can be related to the cytokines also. But we think that sometimes these treatments can actually some of the cells can actually get into the brain, around the brain and the spinal cord, and cause some of these symptoms. So we need to also monitor the patient carefully for this, and manage the symptoms as they develop. So steroids, again, are an important aspect of the treatment of the neurotoxicity. For blinatumomab, again, we'll sometimes stop it until the symptoms resolve, and then we can resume it. Sometimes when we resume it at a lower dose and then build back up to the full dose. And so we also grade this neurotoxicity, grades 1 through 4, as you can see, and you can see the symptoms here. Confusion can be part of this. Jessica mentioned brain fog, headache. Sometimes people can have difficulty finding words. They can get tremors. In the severe form, people can even become unconscious, and people can sometimes even develop seizures. And so the treatment, again, what I've been talking about, steroids, sometimes intravenous fluids, assistance with breathing. Obviously, if someone's having seizures, we use medication to control those. And with both cytokine release syndrome and the neurotoxicity, if it's in a more severe form, we need to hospitalize the patient so that we can monitor them more closely. Other side effects that are less common with these immunotherapies, sometimes the blood counts can go down, and this can contribute to infections. And so we treat that with antibiotics as needed, and monitoring electrolyte abnormalities. We can correct those: potassium, magnesium. Constipation and diarrhea, we treat symptomatically with fluids, stool softeners, etc. And the body pain, and Jessica really talked well about this and some of the medications that we use to treat the aching and body pain that people can develop. So the biggest challenge in managing these toxicities is just being aware of them and recognizing and not ignoring things like confusion, diarrhea, fevers. We need to make sure that we rule out other reasons for these problems developing, like infection. And so we need to be cognizant of that. We need to monitor for limitations. Variability in treatment access, so not all centers are maybe as aware of these side effects, and so it's important that you may maintain support from your main oncologist, who's going to be more familiar with this. And then the balance of when do we stop these treatments or slow them down in order to bring them under better control. And then we need to coordinate the care amongst the different disciplines. And then I think Jessica talked well about the burden on patients and caregivers, so I won't elaborate further on that in the interest of time.
So in terms of the common communication barriers in clinical settings and how to overcome them in terms of open channels of communication, from my perspective, as a patient in this regard, is I felt sometimes, most of the time, that my treatment was just based on numbers and lab values, biopsy results, etc. And if all of these were within normal at my appointment for the stage of treatment that I was in, then my provider would sometimes like question why my overall experience, like why I was fatigued or why I was getting sick all the time, didn't match that. So it almost felt like there was sort of a minimization of the side effects and the daily barriers I was facing while I was on treatment. And this sort of coupled into like the emotional and clinical impact of like feeling listened to as a patient. And I would, get my labs back and, oh, thank God I'm still in remission. Everything's looking good. But then, what is wrong with me? Why don't I feel good? Or, why am I not back yet? And part of that is just understanding what cancer care is and leukemia care, and that it is a long 18 to 24 month process, and your body's never going to be the same, let alone, even close to what it was within 6 months of starting treatment. But by in those appointments and, being told, oh, your labs look good, you're good. Like, why aren't you, walking the dogs a mile yet? Or, like, why can you only make it a block? Or why are you sick again? And things like that. It sort of made me almost like double guess myself of, well, why can't I remember words? And why am I getting sick? So those sort of things I feel like could be improved upon in terms of maintaining a high quality patient care. In terms of like lifestyle, cultural background, personal values, etc., how those can shape treatment preferences. Again, my unique background is sort of a medical provider, allowed me to feel more comfortable in navigating the language of medicine, interpreting my results, and like in my own self-education, having access to materials, understanding research studies that were presented to me in terms of, the immunotherapy and TKI treatment versus bone marrow transplant. So, I was in a unique position there, as opposed to a patient that didn't have that type of background. So I can't really speak to patients that don't have that background, but for me, it was a significant advantage to at least even know the language of what the doctors were talking about, and along with my partner being in medicine too. The role of shared decision-making, I think is important. Again, in understanding treatment, proposed treatment protocols, and ultimately understanding and electing to pursue a treatment and have confidence in that treatment is important. And having the providers present the materials, but then also having the patients be able to digest those materials, I think is important. Some patients I know would just rather, turn their brains off and just be told what to do. And just, they want to put full faith in, and that is, I can understand that. There are times in my treatment where I was in that mindset. And then there were other times in my treatment where I wanted to know exact numbers and studies that things were coming off of. So I think offering the patients the ability to have access to those things would definitely maintain that high level quality patient care. And then in terms of defining what high quality care looks and feels like, I know one of the biggest things for me in maintaining and building trust with my HEMONC and medical team was allowing for open communication. I can email my providers directly, and I don't have to wait for an appointment or, wait for an office to call back. I can, send a quick question, and they can get back to me at their convenience. And then anytime I had any sort of ancillary treatment, like a lumbar puncture or an infusion, etc., the care team that was treating me had full access to exactly what stage of treatment I was in, what I had already experienced in terms of treatments. And so that really instilled confidence in terms of continuity of care throughout disciplines. And then reflections on how patients and professionals can partner more effectively. I think something like this, sharing the opportunity for patients to share their like global experience on the treatment process and not just be reduced to a success or a failure based on labs or biopsy results. Validation that a good outcome is not just qualified as in remission. I think is important, at least from the patient side of things, and preparing patients then for what is remission territory and remission anxiety, and that's a real thing, and navigating that transition from active treatment to remission to then survivorship, I think is something that is important and should be highlighted in treatment. So,
I just want to emphasize the team approach, and that the patient is part of the team. We're all part of the team, all the different members of the healthcare team and the patient, and we need to work together. And the other thing is the recovery can be long. When we used to hospitalize patients more, I used to say that for every day you're in the hospital, it takes 3 days to recover. Now, a lot of the treatment's given as an outpatient, so I could say for every day you get on treatment, it can take 3 days to recover. Mm-hmm. So we underestimate the fatigue and the impact these treatments have, and they're not gone because of immunotherapy. Immunotherapy can still be a factor in all of this. So, and I think this slide really summarizes a lot of what Jessica talked about and what I would emphasize as well. So I won't go through these in detail in the interest of time, but I think these are all crucial points here.